Thanks for the privilege of the podium to Dr. Dostimo and Dr. Drexel. We're just going to go through a couple of case examples today, sort of demonstrating the utility of using radiography to find complications postoperatively when they do happen. I serve as a consultant for Medtronic, but that does not apply to this talk. And many of these cases were crowdsourced, and I'm thankful for colleagues and partners that allow for others to learn from our patients. So this is a 51-year-old male who had an iatrogenic injury during a colonoscopy and ultimately ended up getting an X-flap and primary repair. He developed he had a delayed primary closure of his abdominal wound, but 9 years later, he developed an abdominal wall hernia and underwent a primary repair with mesh reinforcement. He then developed a recurrence about 8 months later with a significant diastasis where he had an ultimate 12 by 5 centimeter ventral hernia. He was ultimately taken to the operating room for a bilateral TAR, but here as we go through his CT scan, this is his preoperative CT that you can see. He sort of has a loss of that posterior sheath there. That lateral, you can see that he's got a significant diastasis as well. He ultimately went into the OR for a TAR, but postoperatively, as you can see on the CT scan, something that you're maybe not expecting, but he represents to the ER with abdominal pain. And you see this large fluid collection that appears to not just be simple fluid, but likely blood. And ultimately, this patient had a rectus sheath hematoma that ultimately was managed conservatively with expectant management, pain control, and reassurance so as to not infect the space, infect the mesh. But ultimately, utilizing our CT scan here, we're able to see the apparent complication of a rectus sheath hematoma postoperatively. This is a 35-year-old male who had a left inguinal hernia that was symptomatic at the time. He had an uncomplicated RTAP performed, a robotic transabdominal preperitoneal repair, and represented as his postoperative visit with left groin pain. He similarly had a CT scan to evaluate after he kept having persistent pain and came to the ER following a postoperative visit. And you can see on this study, this is, as I mentioned, it's our TAP, that he's got fluid in that left groin. That fluid was actually ultimately read by the radiologist as a mesh plug. And in talking with the radiologist, the patient had a previous RTAP that had a medium weight polypropylene mesh that was placed without a plug. But they read it of that material that was in that canal as the patient having a plug that had migrated. And that in fact was not the case. But you can see there in his space of Retzius that there's still a little bit of some fluid, and there's obviously fluid in the inguinal canal. He ultimately represented to clinic 4 months later and completely resolved symptoms with no intervention. And, you know, if we were to repeat a CT scan today, we would see that there's no fluid, but also there wouldn't be any impression of a migrated mesh. This is a 58-year-old male who had a symptomatic supraumbilical hernia. He was ultimately taken to the OR for the repair of an umbilical hernia, as well as a supraumbilical hernia that was identified with a large amount of preperitoneal fat. His defect was 7 by 2 centimeters, and ultimately in the OR, he received a 12 by 10 hybrid bioresorbable mesh. But the patient represented to the ER on postoperative day 4 with abdominal pain, a new bulge, and some significant obstructive symptoms. So he had a CT scan that was performed, and what you can see here as you look at the midline of the CT scan, it looks like he has a completely brand new hernia, complete failure of the mesh centrally at postoperative day 4. You can see that in the middle here, there doesn't appear to be any mesh. This patient had a reinforcement. It was a previous underlay repair. And in the operating room, at least by the operating room surgeon, noted that the patient's mesh had just centrally fractured completely, which, you know, I know in this day and age doesn't happen that often, but had happened in this patient. He ultimately had to go to the operating room multiple times with several and ultimately ended up with an inlay mesh for his current repair and will ultimately likely recur and need a additional operative repair. So this is a 68-year-old female who had a prior history of a ventral hernia about 20 years prior to her presentation to us, and she had significant abdominal wall drainage. You can see on that right side CT scan there the loss of integrity in the epidermis. So she has an open wound as she's presented to clinic. You can see lots of hazy planes in the midline there. And also, similarly, you can see this on the sagittal view here. You can see sort of a ribboning of the, oh, where's the pointer? Oh, a ribboning of the mesh in the superior region, and I'll sort of show you some highlights of, oh, that disappeared. That was unideal. Okay. I was going to show you some ribboning of the mesh where you can see that it has actually fallen away at the edges of that mesh reinforcement. But ultimately, she initially had an incision and drainage at the bedside for the abdominal wall fluid collection. She was managed with long-term antibiotics to sort of get things cooled down and less of an inflammatory state. Ultimately, this is her repeat CT scan prior to her operative intervention, about 2 months. So 8 months from the time of that first CT scan, but 2 months before the OR. You can see that she has a pretty significant recurrent ventral hernia here. And you can see again that ribboning of that mesh superiorly there. You see that wiggling. The mesh has disassociated from the abdominal wall there. You can, oh, that didn't work, but, and she ultimately had to go to the operating room for a stage excisional debridement, removal of her abdominal wall mesh, which was frankly infected. She had an EC fistula that you could see if I could pause the videos, that there was intimately adherent small bowel that was attached to that ab wall was actually in continuity with that infected, that infection in the abdominal wall. So it was an active EC fistula that was low output in nature. And then she was taken back where she had an ultimate abdominal wall component separation with an anterior component separation and placement of a biological mesh. This is a patient who had had a prior incisional hernia repair with mesh and subsequently came with abdominal pain. And as you can see on this CT scan here, they were sort of in their usual state of health. They were actually without fevers. But as you can see, as we travel through these, the stage imaging here, you can see this evidence of air in the subcutaneous area, this fluid collection here, and this person has actually a mesh infection, and they don't have a concurrent EC fistula, but you can see that while there are some flat planes, it's pretty intimately adhered intestine to the peritoneum here. This patient ultimately went to the operating room for a mesh infection after a couple of months from this CT scan, and was able to have a excision of their mesh and a primary fascial closure with a retrorectus repair. This next patient is a patient who had had a prior open incisional hernia repair about 18 years prior to their presentation. They had had a remote small bowel obstruction as well that required a 5-year later exploratory laparotomy. And you can see that this patient on this CT scan has some calciphylaxis of their mesh over here. There's some separation of the mesh laterally, and they've clearly recurred in terms of, they've clearly developed a hernia in the midline here. So they've clearly don't have, no longer have apposition of their mesh. Their mesh has failed also centrally. You can see here this patient has some sarcopenia of their rectus complex as well, but also some calcium deposits that you can see here on the mesh that's presented here. And these images are courtesy of Jenny Shao. This next patient is a 52-year-old female who had a prior LAR and oophorectomy and had a resection of a pelvic mass and presented with an incisional hernia. She was actually really quite symptomatic secondary to this hernia at her prior extraction point, which was done in the midline. You can see she has a defect that's mostly fat-containing on this CT scan. She ultimately went to the operating room for a robotic repair. And she had lateral port placements. The superior port was a 12-millimeter port, and the 12-millimeter port was closed according to the operative report, but the two 8-millimeter ports were not closed, and that was the inferior as well as the middle, the mid-abdomen port on the left side. However, unfortunately, the patient represented with abdominal pain with another hernia. She presented, though, with abdominal pain in that's a typo, there in the left upper quadrant postoperatively, and her CT imaging demonstrated that she'd actually developed a Spigelian hernia at the site of that 8-millimeter port in the left lower quadrant, which was actually not where the patient is symptomatic, and the patient at this point is not going back to the operating room for repair. But we can see that even though, many of us don't close our 8-millimeter ports, or, we can pull the audience who is actually closing their 8 millimeters, but the patient has developed a hernia in that area. So a hernia begetting another hernia, as you can see there. Our final patient is a prior laparoscopic ventral hernia repair with mesh who had a subsequent umbilical hernia recurrence. She underwent a paniculectomy with no primary repair at the original paniculectomy operation, though it was noted that she likely had a hernia at that time. She presented with right lower quadrant pain and a bulge. As you can see on the CT scan, the patient has a pretty decent sized hernia there. And this is in that setting of the patient, 3 years prior when they had the paniculectomy is likely should have had that hernia repaired at that time. And then finally, this is a patient who had a small 2-centimeter defect who ultimately went to the operating room for hernia repair, and this patient had a TAR, but as you can see in some of our prior images of the other presenters earlier today, you can see that this patient has a semilunar, linea semilinaris injury, has a complete violation of the neuromuscular bundles, and now has bilateral hernias there. I'll pause so you can take a picture. And then you can also see, this is just another additional view of sort of the thinning of that rectus muscle. It's, pretty, not a very large complex. Oh, our final picture. This is a patient who I don't have any of the preoperative imaging to, but you can see that this patient has after a TAR, they have a posterior rectus sheath, complete breakdown, as well as likely a denervation injury and a complete recurrence of their hernia. So while we should use preoperative imaging to guide what we do in the operating room and then subsequently, hopefully choose the right operation, we can see that, ultimately even at times it can be patient protoplasm, but there certainly can be technical complications that we do in these operations that truly hurt our patients, but the ability to utilize CT imaging and understanding the planes as was described in prior presentations earlier can help us see and utilize radiography to find these complications postoperatively for our patients. So thank you.